name is Kristoffer. I'm a regional director with Silverado, the world leader in providing care for those with memory impairing diseases. Now, whether it's through our innovative clinical models of care for our residents, our world acclaimed evidence-based Nexus program for early stage dementia that combines science and social engagement, or the many partnerships with global leaders in medical and scientific research, Silverado is not only committed to changing the lives of those with memory impairment, but through education and by example, eradicating the stigmas that surround all dementias. We are currently changing lives in 20 communities across 6 states, and will soon impact even more lives as we open our new communities in Thousand Oaks, California, and Bellevue, Washington, which are both due to open in the next 2 months. And so speaking of Bellevue, Washington, our esteemed speaker today is based just across Lake Washington in the beautiful city of Seattle. Dr. Kristoffer Rhoads is a clinical neuropsychologist specializing in the evaluation and treatment of dementia and neurodegenerative disorders. He is a member of the board of directors of the Washington chapter of the Alzheimer's Association, and he chairs the Health Medical Care Subcommittee for the Dementia Action Collaborative, implementing the Washington State Plan to address Alzheimer's disease and other dementias. He currently serves as a neuropsychologist for the University of Washington Memory and Brain Wellness Center at Harborview, and he's an associate professor in the Department of Neurology at the University of Washington School of Medicine. So Dr. Rhoads, thank you so much for joining us today, and I'm going to hand off to you.
You know, it is an absolute honor and a pleasure to partner with you today and Silverado in general to talk a little bit about some updates in the prevention and treatment of Alzheimer's disease and related dementias. And I really appreciated your comment around decreasing stigma, as that is part and parcel of the work that we do here at the University of Washington Memory and Brain Wellness Center, including our clinic, but also one of the longer running Alzheimer's disease research centers, which is in its 37th year of continuous funding. I did today want to give you a little bit of an overview, some updates around what we know about Alzheimer's disease and other dementias, and really focusing more on treatment. And my favorite part of my job is that I don't prescribe medications. I get to do all the non-pharmacological and behavioral and lifestyle interventions and more of a cognitive rehabilitation approach. And a big piece of that are the programs and services that we offer here and that I've seen popping up from around the country. Very, very briefly, I don't want to bludgeon you with a lot of statistics, but I do want to draw your attention to the fact that dementia and Alzheimer's disease are worldwide problems. This is not constrained to the United States or Western countries. We know that there are somewhere north of 50 million people living with dementia currently. That is kind of a tip of the iceberg when you think about prodromal phases of mild cognitive impairment or even pre-mild cognitive impairment, where someone may have the beginnings of neurodegeneration that haven't manifested clinically. So we're talking, you know, a huge segment of the population and a number that continues to rise. So we know about 10 million new cases of dementia per year. So that roughly equivocates to about 1 case every 3.2 seconds. And when we think about where this is occurring the most, these are in low and middle income countries who occupy about 58% of the dementia landscape or proportions, which will increase to almost 70% by 2050. And there are a variety of healthcare as well as contextual factors that drive that, some of which intersect with genetics and predisposition, but really it's, as we will see in a bit here, the contextual factors in which someone lives is a huge predictor and dictator of who will go on to develop cognitive impairment and dementia, and which opens the door for some thoughts about prevention and intervention. One of the statistics that is continuously staggering to me are the number of people who are undiagnosed. And these aren't necessarily folks in the mild stages who have some short-term memory difficulties or maybe some word-finding problems. These are individuals who have functional impairment because of acquired cognitive changes. So we know here in the United States, only 45% of people with dementia have a diagnosis in their medical record, which when you think about that, what other healthcare condition would fall into that category? Could you imagine if 45% of people with cancer had a diagnosis in their medical record? Again, multiple reasons for this, but it makes care so much more complicated, everything from a covering physician who doesn't know cognitive impairment is part of the mix, that is a mediating variable for how people do other diseases, to unplanned or even planned hospitalizations or surgeries. A lot of impact in terms of how people recover from those things, how they fare in the hospital, rapid readmissions, many of the metrics that we're worried about in healthcare, and many of the metrics that people are worried about just in terms of quality of life. So we know that about 10% of people in India have a diagnosis. So this is a big issue, and we are working on changing that, as are many other groups around the country and around the world, but we've got a lot of work to do. More locally, here in the United States, about 5.8 million Americans with Alzheimer's disease. Maybe 5.2 million of those folks are over the age of 65. We certainly see individuals who are in their 30s or 40s with Alzheimer's disease and Alzheimer's dementia. We know that age remains the greatest risk, such that after 65, there's about a 10% general population risk, but that starts off very low at around 3% in the age band between your mid 60s to mid 70s, escalating up to about almost maybe a third, maybe even 40% by the time you hit 85. And again, there's a big distinguishing factor here in terms of having the disease of Alzheimer's disease, right? The plaques and the tangles that constitute that versus the clinical symptoms and the functional interference that characterize dementia. So you could have the disease and have no symptoms. You have the disease, have mild symptoms, or have the disease and have dementia. We'll come back to that. That's an important concept. We also know that these large numbers obscure some very, very important differences in terms of disparities for underserved and historically marginalized populations. So our African-American counterparts are about 2, maybe 2.3, 2.5 times as likely to have Alzheimer's disease than Caucasian counterparts. We know that Latinx populations tend to have both higher prevalence as well as be diagnosed later and with more severe symptoms. And that the vast majority, about 66% of individuals with dementia are women. And some of that is related to age and differences in life expectancy. Some of that may be related to hormones or other either biopsychosocial factors. To drill down a little bit more specifically and to provide a snapshot of what is occurring on the state level, here in Washington state, we have about 120,000 cases, about 7 million people in our state. And that's an increase from 2010-ish, but it really hasn't changed in the last couple of years. We are still expecting a significant increase up around 150,000 by 2025. Here in Washington, as in many other places, it remains one of the highest leading causes of death. We historically had the 3rd highest rate in the US, behind North Dakota and South Dakota. We are now at the 6th. And some of that is state by state better job of public health accounting and calling Alzheimer's disease as a cause of death or the primary cause of death when it is, versus attributing it to pneumonia or some other condition that took hold because of Alzheimer's disease. And then these numbers are the ones that tend to impact me the most, particularly as somebody who works with individuals with memory loss and their families, are the unpaid workforce who provides care. So here in Washington, it's an unpaid economy on scale of a major corporation, right? So $5.3 billion worth of care if you were to pay those individuals for the work that they do, to the tune of $250 million in additional healthcare costs for those caregivers. And for any of you who are frontline, family, professional, or combination caregivers, I don't have to tell you the physical, emotional, and psychological toll that this takes. And often the caregiver's healthcare takes a back seat to the individual with cognitive impairment or dementia. So as we came up with our own state plan for how are we going to address this kind of silver tsunami and impending crisis that could be and is Alzheimer's disease, we asked the question of our legislature of if 10% of this unpaid workforce can no longer provide the services that they're providing, do we have the support systems and structures to step in to fill those gaps? And the answer was a resounding no, no way. We can't help the people who we know of currently with the things that we have, we need to be doing better. And all of these statistics that we just kind of ran through are pause to rethink Alzheimer's disease. And we know that the changes that come with aging are many, and some of that is visible and obvious, wrinkles, or maybe you lose some height due to decreased height of your spinal column. But other things like changes in cognition are a little harder to assess, and it's one of the most frequent questions of what's normal and what's not as we get older. We know short-term memory changes, and after decades of research, we have a good sense of how much, at what ages, and what parts of short-term memory change, which is a little bit out of the scope of today's talk. But this idea that, well, Alzheimer's disease is just an inevitable consequence of getting older, absolutely not. And we've got a much better understanding for aging that is successful and healthy, and what does that mean, and how do people get there, and how can we do more of that, as well as treating illness when it arises. And it really has made us rethink the stigma around Alzheimer's disease, which I really would imagine is a big driver of why only 45% of people are diagnosed. It's hard for people to talk about. It's hard for primary and other specialty care providers to talk about and assess. So it's in the shadows still a bit. So again, I'm extra appreciative of your attendance here today as you learn more and work to combat that stigma in your own communities. And one of the things that I will emphasize here is that one of our unique focuses or areas of focus is resilience and these ideas of retained strengths, that not everything changes in Alzheimer's disease, and how can we capitalize on those retained strengths to promote function. So if we think about kind of what's normal, what's not, we have this kind of graph of cognitive function and then over time. So these are decades or years. And this green line represents kind of the normal age-associated changes, typically in things like how quickly we can process information, short-term memory, not long-term, or procedural memory. Memory for facts or how to do things tends to remain quite intact, some of which even in the early to mid stages of Alzheimer's disease, and you can capitalize on that. So around 65, there are these kind of cardinal sets of changes that occur, and there are some progressive changes after 85, not to the degree that impacts function. It may take longer to do what you need to do. You may have to work harder. It may be that you have to go back out into the kitchen to remember what you're going to go into the living room to get, but typically you can do what you need to do. Contrast that with this other process, something like Alzheimer's disease, where there's this gradual set of changes that occur at the microscopic level in the brain, things that wouldn't be visible to the naked eye, even on autopsy. And these are the plaques and the tangles that you've likely heard about with Alzheimer's disease and the characteristic components of neurodegeneration. And these gradually increase over time, such that by the time they hit a certain level and start to affect the structure of the brain, so the neurons and even larger regions, there are changes in cognition. So these plaques and tangles are pathological to the brain, causes degeneration of brain networks and regions. That gives rise to changes in cognition, which are kind of the symptoms of that. So again, you could have this disease process way over here on the left where it's going on, but you don't have any symptoms whatsoever. You could be in the territory of mild cognitive impairment, which is a measurable difference between normal aging and how we're doing on things like tests of memory or language or executive functioning. Or if those plaques and tangles and other pathological burden increases and cognition decreases such that it interferes with your ability to pay your bills or manage your medications, transportation, live independently, that's where we cross the line into dementia. So dementia is not a disease per se, it's a term that describes functional impairments that are caused by changes in cognition. And when we think about all the things that can cause dementia, there are many, there are hundreds. Alzheimer's disease is one of, if not the most frequent, but it's not the only one. So again, it's kind of an umbrella term, and not as part of today's talk, but certainly excellent information out there around the differences between types of dementia. I've got this here as a resource, and I'd be happy to provide these slides to our gracious hosts if they want to disseminate them. But this kind of breaks down the rough prevalence. So you can see about 2/3 to maybe 3/4 of all dementias are either due to Alzheimer's disease or have a significant component of Alzheimer's disease. And we can kind of work through the things that change and which parts of the brain are associated. The characteristic of Alzheimer's disease typically is something that starts very slowly and creeps on over time. There are no focal or datable events like a stroke or a brain injury. And there is a progressive decline versus something like Lewy body dementia, where there are significant fluctuations. Some days people are kind of at their baseline, and other days more prominently confused, can happen within days. You can see some of the other changes that distinguish these things. So this really, again, more for reference. What I think is also important to talk about is this question of, if I have Alzheimer's disease and if I'm starting to show symptoms, how long do I have? That is a common question of, is it going to be a year before I have more prominent problems or functional problems? And that's a hard question to answer. And we can prognosticate to a degree, given what we know about the different stages of Alzheimer's disease. You could be pre-symptomatic for anywhere between 5 to 20 years. You could be in the MCI phase for a year to a decade. And then once you're diagnosed with dementia, you could live for 2 years to 20 years. So when you put all these together, this is potentially a 50-year disease. And some of the things that dictate how long people stay in these different stages are other health conditions, your age at which you're diagnosed, the severity at which you're diagnosed, what you do about it, how you respond to the medications that are available. So there's a variety of different deterministic factors that will shape length within these different bands here. But I guess what I would want to impart is that it is not a death sentence. It is not a, you've got Alzheimer's disease, there's nothing you can do, here's your Aricept, good luck to you. That is absolutely not the story. And unfortunately, it's been the story for a while. So my hope today is to also convince you that this is not something that can't be worked with. Which gets us into the idea of treatment. So if we go back to the slide of gradual accumulations in neuropathology at the bottom in red, and this kind of change in cognition in yellow, right now, there is no vaccine for Alzheimer's disease. There is no disease-modifying treatment that cures it or restores memory back to baseline levels. But there are things that we can do, and there are medications under investigation that seem to suppress that accumulation of pathology. So instead of this kind of sharp curve, it's still happening, but it's not happening at the same rate. And what that effectively does is keeps people in the milder stages. And the state of the art right now are these multimodal interventions that, again, it doesn't cure Alzheimer's disease, it doesn't fully prevent it, but if you can prevent late stage disease or mid stage disease where the greatest functional loss is, or need to transition to a different level of care or more neuropsychiatric symptoms, whatever it may be, if you can prevent that, that's a huge advance. So how do we do that? And I'm just gonna put it up here. This is, we surveyed literature around what's available in the treatment of Alzheimer's disease, prevention and treatment. This is kind of the full package. So paramount would be treatment of all the modifiable risk factors, beginning as early as possible, ideally in midlife, but it's never too late. So if you're someone in your 70s or 80s, I would also disabuse you of any myths that, well, it's too late for me, the horse is already out of the barn. No, horse can go back in the barn. So we want to make sure we're treating all the things that we know about for cardiac and heart health. You think about the brain, and what goes for the heart kind of goes doubly for the brain. We want to get people moving. So this sitting disease that we have, getting people moving physically, getting people moving mentally, keeping them engaged, avoiding cognitive retirement. Treating sleep disorders, we have a greater appreciation over the last 4 or 5 years for the importance of not necessarily quantity of sleep, but quality of sleep. And what happens as we get into deep stage restorative sleep, N3, REM phase sleep, what that means for how the brain kind of repairs itself or clears out amyloid beta, what it means if you have Alzheimer's disease in terms of speeding up accumulation of amyloid beta. So stay tuned for that. We're learning more and more. And then other lifestyle things that we know are not good for brain health, like intervening with excessive alcohol intake, a thorough review of medications, both prescription and over-the-counter medications. We see a surprising number of people who are taking things like Benadryl or other sleep agents to help with sleep, but they have side effects that are certainly not good for your memory. So a thorough review of medications you're on, over-the-counter supplements, and then medication options, things that are FDA approved for Alzheimer's disease and cognitive disorders, cardiovascular exercise, cognitive activation, cognitive rehabilitation, dietary interventions, managing stress well, meditation, MBSR or mindfulness-based stress reduction being one method for that. And then perhaps most importantly, that can help serve some of these other things are keeping people with memory loss and dementia engaged in their communities. And I want to spend a fair amount of time talking about that. So let's go through each of these areas somewhat briefly, but I'll give you some resources that you can take a deeper look if you're interested. So in 2017, the Lancet Commission pulled together an international group of experts, researchers, clinicians, and took a survey of what do we know about Alzheimer's disease from prevention to end-of-life care. And at that point, they determined that about 35% of all dementias are preventable. And with the revision that just happened last year, that number, fortunately, has gone up to 40%. So if we kind of go through the different areas, it's the lifestyle or lifespan intervention also. If we could improve early childhood education, that would eliminate 7% of all dementias. Part of that is building cognitive and cortical reserve. Part of that is increasing healthcare literacy and providing better socioeconomic opportunities. In midlife, if we could address hearing loss or prevent hearing loss, that would get rid of 8% of all dementias. And a complex relationship between hearing loss and the brain, and what happens in the cortex as we experience sensory change, traumatic brain injury, doing a better job of protecting the head in car accidents or sports, hypertension, alcohol, obesity, late life, smoking, social isolation, depression, all these things. If you put all these together, you can eliminate 40% of all dementias. And that, as we're going to see in a minute here, potentially offsets the risk of things like genetics, which we can't modify. So there's definitely a role for prevention, and it's been fascinating to see our departments of public health, the CDC, other organizations take a strong interest in what can we do around dementia prevention, as we also focus on providing treatment for people who need it. And that treatment takes multiple forms. So here's some data on one of the FDA classes or approved classes of medication for Alzheimer's disease. And if you're not used to looking at these graphs or plots, the way this works is this line here with the 0 would be there's no difference between a placebo or a sugar pill and the medication. Anything that is over on this side is a positive treatment effect. Anything over here would say actually the treatment makes things worse. And as you can see, there's a small treatment effect across all these studies that kind of averages out to right here, which is not a profound, restorative, huge disease-modifying intervention, but as we know clinically and from other studies, things like Aricept or other medications help with symptoms and may stabilize things for a period of time. For some individuals, there's a pretty wide response. So there's a role for these. Similarly, the other class of medication, the NMDA receptor antagonists, also have a pretty decent treatment effect. Smaller studies, fewer studies, it's a newer class of medications. So it's not the kind of treatment effect like insulin for diabetes or statin for cholesterol, but it's not kind of what you sometimes hear, which is they don't do anything, there's no point in trying them. The data would argue otherwise. And I put these here not to endorse any medications, but just give you a survey of what do we know about the FDA approved medications that are out there, and then how does that stack up with the other things that we could do. So now if we look at that same kind of a meta-analysis on cardiovascular exercise, you see the same thing, that the treatment effect is overall, there's something there. And this is in people with full-blown dementia. So the data also suggests, and there might even be a greater treatment effect in MCI, or the earlier we do these things, the more window of opportunity we have to intervene. So again, it's not a, if you're already into mid-stage or late-stage dementia, there's nothing to do. Just the window is closed quite a bit. So the earlier we do these things, the better. I suspect that at least some of you have a question about what should I be doing, and most of these things are indeed cardiovascular exercise. So things that get your heart rate up in your cardiovascular training zone. You always, always, always would clear this with your primary care provider or cardiologist or other healthcare provider who knows you well. But the data is pretty impressive, and of the things you could do, and I'm kind of sorry the answer is exercise, but if the things that you could do that have an impact on your cognitive functioning, your dementia risk, cardio is it. The studies would suggest that we're somewhere in the territory of 20 to 30 minutes, 5 times a week in that zone. There was another lovely study that was done that looked at 45 minutes 4 times a week, at a little more intense rate, but still 60 to 80%. And the effect is about the same. So again, that importance of physical activity. And when you think about what that does around blood flow and sending almost double the amount of fuel to the brain, what that means in terms of production of the neurotransmitters that the brain uses to communicate, stimulation of connections between the neurons that are still healthy and working. There are 4 or 5 mechanisms by which this is a plausible intervention. When we look at the same kind of idea, but with cognitive activity, so keeping your brain exercised, there is also a modest effect. These are things like crossword puzzles, jigsaws, all the things you hear you're supposed to do. There's some benefit to keeping your brain active. When we get into more detailed actual cognitive training, so these would be the computerized or paper and pencil programs that are designed to really push your brain more than just activating it, but actually training up specific types of cognitive functions. In mild cognitive impairment, you can see that there is a more significant effect than there is in frank dementia, which again stands to reason that in an earlier stage, there's a wider window for intervention. And I would disentangle that from cognitive rehabilitation. So these would be things like activities that are designed or delivered in a medical context by either a speech and language pathologist, a cognitive rehabilitation specialist, a neuropsychologist, that focus on either strengthening or capitalizing on neuroplasticity versus coming up with things that help us compensate. So a MediSet is a great example of that over here on the right, where if I have memory problems that interfere with my ability to track my medications, so the things internally that I would normally rely on aren't working the same. If I put some things into practice externally, like a MediSet coupled with some alarms and reminders, and maybe even a tracking sheet where I can write down the time that I took it, that's a great example of a compensatory strategy. And likewise, when we think about memory, short-term memory, there are 4 basic components to short-term memory. You have to pay attention, you got to get it in, you got to keep it there, and you got to pull it back out when you need it. So encoding, getting it in, storage, keeping it there, retrieval, pulling it back out when you need it. And there are different interventions depending on which part of that process is breaking down or experiencing more problems. And that's the benefit of the detailed memory testing that we do, is we can disentangle those things. People are also curious about what should I be doing diet-wise. And the MIND diet is the best studied at this point. It's a derivation of the Mediterranean diet. It comes from our colleagues at Rush University. This was a lovely study that's, it goes back about 6 years now, 5 years, looking at about 1,000 people, age 58 to 98, and followed them for 4.5 years. And they were randomized to diet as usual versus the MIND diet, which is the DASH diet, the anti-hypertensive or high blood pressure diet, coupled with the Mediterranean diet. They got to have 1 glass of wine, which I think they threw in there to make sure people did it. And what they found was that for the people who stuck to the MIND diet pretty rigorously, over that 4.5 years, there was a 53% reduction in who developed Alzheimer's dementia. They didn't check to see if you had the disease, but not the clinical symptoms. So it's possible, but certainly didn't have the outward memory problems or functional problems. For those who stuck to the diet modestly, it was about a 35% reduction. So again, it's not an all or nothing. And when you think about diets, if any of you have tried to change your diet wholesale, it is incredibly hard to do. And one of the things that I like about this is they provide practical suggestions around modifications that get you closer. So worth investigating. My understanding is that they are doing a trial now as more of an intervention for people who have diagnosed and obvious memory changes to see, does it change progression. So stay tuned. I haven't seen any updated data yet. So we can also, there's similar data if we look at mindfulness-based stress reduction programs in terms of coping with cognitive changes. But all of these things really speak to the importance of the choices that we make, the things that we can do that are within our sphere of influence. And that's, in my experience and my bias as a neuropsychologist, that's where people are most interested. Like, what can I do? And sometimes there is this, well, I've got the diagnosis after months or even years sometimes of going through different procedures. I've got a diagnosis, now what? And these things are the now what, right? How do we get you moving? How do we get you eating better, sleeping better, dealing with stress better, staying engaged in your community? And some data that was presented at the International Conference for the Alzheimer's Association back in 2019 was that the more of these things we do, the more benefit they seem to have. So these are the 5 kind of common factors here: healthy diet, physical activity, light to moderate alcohol intake, so a serving, which you need to get specific about that. A 1/5 of gin is not a serving. I learned that when I worked at the VA. And smoking, no amount of smoking is safe. And then cognitive stimulation. So if you do 4 or 5 of these things and are pretty committed to them, don't have to be perfect, that confers about a 60% lower risk of Alzheimer's dementia. If you do 2 or 3, that might be a 40% lower risk. And our risk for things like ApoE4 or other known genetic risk factors that aren't fully penetrant deterministic genes, which tend to be more early onset, this may be significantly more than that. So we are not just our genes, I would say that. I would also say these things are not easy to do. They sound simple, right? But it takes commitment, it takes discipline, it takes support, and some partnership with your providers to do these things. Accountability is a wonderful thing. In the name of time, I'm not going to spend too much time on this, but I did want to tell you, for those of you who aren't in Washington, that your state has a similar infrastructure, but depending on where you are, it may be at a very different place. So we have a national plan for how we're going to address Alzheimer's disease, and there's 2 main pieces of this. One is prevent and effectively treat Alzheimer's disease by 2025, and we are knocking on that deadline closer and closer. And also, if you look over here in 2011, federal funding for Alzheimer's disease was pretty abysmal. And due to a variety of efforts, including the Alzheimer's Impact Movement, research dollars in Alzheimer's disease have logarithmically increased almost, which is wonderful because it attracts brilliant young scientists who see a viable career path and typically have a personal connection to the disease. So it's been great to see this be so well supported by NIH. And we are, for the first time in the 20 years that I've been doing this, I feel pretty confident that we're on the cusp of something very significant in terms of treatment. So each state has to have its own exponent of that and local delivery. And boy, true here in Washington, true in all the other states I've been to. States are heterogeneous places. So Eastern Washington is very different than Western Washington. The Seattle area is very different than Southwest Washington. So it's lots of needs, lots of different regions, resources, geography dictates some things. And this has been a long process, but what started in 2013, led to our first products in 2017. And our state plan, which was a governor-appointed work group that created this plan, transitioned into an implementation group. And this is where I think we've been successful, is this large interdisciplinary group, including people with Alzheimer's disease and care partners, as well as legislators and people from the clinical and research worlds like myself. And we were tasked with what can you do with no money that has high impact? And we did. So we created a dementia roadmap for people living with Alzheimer's disease and other dementias. We've received over $1 million in state funding with another set of asks that is before the legislature right now. Tough time to ask for money, but we've got a proven record of doing things without it. I'll give you an example. So the roadmap is a really fantastic resource, and that number of 75,000 I think is a conservative estimate, but it takes you all the way through wondering and worried, all the way to I've got late stage dementia. What are the things that we should be thinking about? What are the resources that can help? It is, to a degree, Washington state specific, but the analogs of the different programs and services and organizations are out there. And as a matter of fact, for a lot of our tools, we relied heavily on things that came out of Minnesota. Some expanded early stage programs. We've got some webinars on if you're interested in starting an Alzheimer's Cafe, how would you do that? Here's a 6-page list just updated a couple of weeks ago of virtual resources for caregivers. So lots and lots on there. And the last thing I wanted to talk about that we have embarked on as of June is a virtual education, a virtual clinic for primary and allied healthcare providers in rural and under-resourced parts of the state, where we have an expert hub here at the University of Washington, consisting of an interdisciplinary team. And then we've got spoke sites, providers out in the community. We meet twice a month. We do a very brief kind of a lecture, kind of educational piece, and then we do cases. And it's an all teach, all learn, case-based learning model. And so far, we've provided almost 250 hours of instruction. You can see our sites here. We've got plans to expand down the West Coast. Stay tuned, it's a little early to talk about that. But it has been amazing. We've got 22 sites, 53 providers that are participating. And what each one of these stars becomes is a local resource for dementia care. So we've got people now across the state who are the go-to for, if I have this kind of an issue with a patient or in my system of how do I do this, these are our local champions. And in the name of leaving about 10 minutes or so for questions, I wanted you to kind of be left with this, which is really our ultimate mission, which is how do we help people and partner with people living with memory loss and their families to have as good a life as possible. And as somebody with a personal connection to the disease, I wouldn't sugarcoat it and say it's, boy, what a great challenge to, add to your later years. This is hard. This is one of the hardest things to deal with for spouses, for family members, and the idea that there are some positive aspects and the idea that there are things that we can do to help and maximize those, that's the approach that we want to take. So to preserve function, to keep people engaged, and if you can't fight this, you might as well dance with it and try to lead as much as possible. Some resources, which again, these are some national, some local. I will thank you for your attendance. I'm going to leave my contact information up here. I also like this picture because, lest you think I'm in the ivory tower of the University of Washington, I am in the brick tower of Harborview, which is our regional level 1 trauma center. And I really still identify as a clinician primarily.
First of all, Dr. Rhoads, thank you so much. Wonderful presentation, so much to take away. And thank you also for offering to share the slides. I know a number of folks have asked, and we'll be happy to distribute those. So thank you for that. We do have a number of questions, and we'll try to get through as many as we can. One question came up, and I got to tell you, hearing you talk about the programs, the approach that you're taking, and I mentioned, our Nexus program early on. We base it on pillars like cognitive exercise, physical exercise, stress reduction, purposeful social activities, support groups, right? What we have seen is that, academic research has validated the participants in our Nexus program. They show a statistically significant 60% improvement in cognition when compared to those without such treatment. And we're seeing what you're seeing. So the question is, and I love your term diagnose and adios. I'm going to steal that, by the way.
Please do. I stole it from somebody too. So.
So the question is, given that we see these benefits, given that so many of the experiences that we hear often is somebody diagnoses, maybe you get some Aricept or Seroquel, as you referred to earlier, and then it's adios. So how do we train the greater medical community, those on the front lines, to pay a little bit more attention and to really deliver this message that we are seeing through our Nexus program, through what you're seeing? How do we get the message across so that people have a better experience at that initial diagnosis?
Boy, that's the $64,000 question. And our approach is that it has to happen at all levels. And we have been pretty intentional around working on changing training at the graduate level, graduate medical level. But you also need to reach the providers that are out there in practice that didn't get a lot of training. So one of the first things that we did for our state plan was to do a survey of primary care providers. And we had about 250, 275, I think, respond, which is a pretty decent number. And 79% said, this is absolutely important. I have no idea what to do. Didn't get any training, don't know how to bring it up, don't know how to talk about it, don't know what tools to use, don't know what treatments exist. So the training needs are huge. And my take on it is that primary care specifically want to do the right thing. They just don't have time, they don't know what to do. So it has to, there have to be educational programs. There has to be incentive. So it's been really interesting to see these new billing codes come through that will reimburse providers at high levels for doing the work. The challenge is, unless you also give them the note templates and way to interface with their electronic medical record, or, I don't know that mandated education is the way to go, although the Massachusetts model is very interesting, where providers need a certain amount of CME around dementia care in order to renew their license. So you got to have a provider base that's incentivized to do it. We're presuming they want to do it. But then you also need to have a public and population that knows what to ask for. Like, hey, my Medicare annual wellness visit's coming up. This is a great time to maybe check out my cognition, right? And then you need programs and services for providers who can't do it all to be able to refer people to. So it's got to be this kind of three-part piece, or otherwise they don't gain much traction.
Got it. Okay, thank you. Question that we have here also, you talked earlier about the benefits of sleep or quality of sleep. And so a question that we have here is, what is the safest sleep aid for the brain if you have trouble staying asleep?
Yeah, cognitive behavioral therapy for sleep. Any kind of behavioral interventions, the order in which we proceed here, and sleep is such an incredibly common thing. I would say of the people who come to our clinic who have cognitive problems that look an awful lot like Alzheimer's disease or something like that, that don't end up having Alzheimer's disease, undiagnosed, untreated sleep apnea is in the top 3. So that's one of them. So the first line of intervention would be just the basic sleep hygiene things, which again, they sound simple, but we don't always do them. So limiting screens for 45 minutes before you go to bed, making sure the bedroom is, it's for sleep and sex only. It's not, you're not doing work in there, you're not watching TV in there, avoiding caffeine, exercise. There's a whole, basically nicely outlined series of things we can do. So that's number one. The next level of intervention, if that's not quite working, would be something like melatonin. And then you can start to get into some other things, like some of the other medications like trazodone, and then you can escalate from there. But I'd say the behavioral things first, melatonin second. And always, obviously always talk with your provider about anything you're thinking about trying. Or if you're stuck, if you're like, I've tried these things, I've done as much as I can't, it's not working.
Understood, okay. Mark has a question. He says, your presentation is excellent. I'm doing the things that you describe as difficult, specifically in terms of exercise and diet. Yep. I'm thankful that you did not go into all the meds. My question is, do I help myself by taking a daily pill, something like a vitamin or any of the OTC memory meds now in preparation for the future?
That is a great question. So the literature that's out there right now everything has kind of come up as a wash, and things have been investigated like vitamin E, B12, ginkgo biloba. I mean, it feels like every year or so, coconut oil. I mean, there's always something, right? And the best data that I have seen, and I'm channeling my providers that I work with here, would say unless you have a deficit in something, these extra levels of things likely not helpful. There may be individuals who are really responsive to that, but until we know who they are, by and large, there's no data that would support that, unless you have a deficit.
Okay. All right, Shannon is asking.
And boy, supplement companies would love to separate you from their money.
Very true. Shannon wants to know, she says, I'm curious if there's been any correlation found between a history of mental illness and dementia. Additionally, as lifestyle factors are so impactful, have there been studies that link sleep apnea with dementia?
Yeah, so yes and yes. So it's a complicated relationship. So there is data that would suggest long histories of major depressive disorder, PTSD, especially if not treated, raise risk for later life dementia. And there's a complex interplay of kind of what happens from a neurochemical and biological standpoint that probably opens the door for that. And there's some arguments around, does it cause it, or does it maybe open the door sooner? So if you're somebody who would develop Alzheimer's disease at 75 and you have a lifelong history of untreated depression, is it now 65 that you're experiencing that? That's a little murky. But yes, there is an association between those things and later life dementia. Not necessarily for episodic kind of situational things. I mean, we all have things that go south and have a hard time with that. That's a very human kind of thing. And not necessarily for depression that's well treated. So it's, again, complex, but yeah. And then sleep apnea, yes. And when you think about sleep apnea, you get two things, right? I mean, for a lot of folks, they get oxygen desaturation, so mild hypoxia. And one of the parts of the brain that's most sensitive to that is the entorhinal cortex and the hippocampus in your temporal lobe, which is also one of the first places that Alzheimer's disease unfolds. So it's, again, like opening the door for a pathological process. Less so for treated sleep apnea. You still get the sleep fragmentation sometimes, which is the not getting into deep stage restorative sleep. And that can be a little disruptive for cognition, but likely doesn't confer the same risk. Good question.
Absolutely.
All good questions.
All right. I think if you're okay, I'm going to squeeze in one more. We're trying to get as many as we could, and I appreciate everybody with all the questions. I'm going to squeeze one more in here. Sheila wants to know, what are your recommendations for those you serve who are not mobile and in a wheelchair? Do you think breathing exercises can be comparable to the cardio that you recommend?
That's a darn good question. So we work with a lot of folks who are mobility impaired, and I look to my rehab colleagues, like my physical therapists, occupational therapists, for, is this somebody who could do the arm bike, right? So you want to get the heart rate up, and doing that being stressed out is not the right kind of thing. Doing that by restricting or otherwise changing your breathing might not be the right thing either. But I look to water-based activities. So even walking in water, which offers a fair amount of resistance. Depending on your age, we're not talking about heroic heart rate levels. These are not levels at which you feel like you're going to pass out, or it's a brisk workout. And getting creative about how to do that when somebody has impaired mobility, you sometimes need to lean on your other colleagues who are crafty and have some suggestions there.
Dr. Rhoads, thank you so much for your time, the great work that you do, your team, and everybody at the University of Washington for this wonderful presentation today.
My pleasure. Thank you for having me. Thanks for the offer. And again, thanks to everybody in attendance. I appreciate you spending your time this way.